Can he?
Hello.
Can you see us, Dr. Yang?
Yes, I can see everyone.
Perfect. Welcome to the room. Hi, everyone. Thanks so much for joining us. I'm Gabriel Seidman from the Ellison Institute, one of the partner organizations that helped set up this event. Huge thanks to the Rhodes Trust for leading on this and inviting us to have this breakout session today. Just to make sure everyone's in the right room, this topic is market shaping to support access to essential pandemic tools. We've got 4 distinguished speakers here who I'll introduce quickly. In the order I have them on my sheet, we have Dr. Richard Hatchett, CEO of CEPI, Dr. Ji Yang, the chairman of BVCF Investment Fund, Hala Audi, CEO of Unizima, did I get that right? And Dr. Sergio Carmona, Chief Medical Officer for FIND. And before we kick off, I just want to make a couple remarks just to help frame the conversation today. I think one of the things we heard, and a lot of people in this room I'm sure know better than I do, the global health community has a really successful and strong track record around market shaping for specific commodities, for specific products, and for responding to global health more broadly. The themes I think that are going to come up, I'm hoping will come up today, is specifically around how can we promote market shaping and influence the private sector to build entire ecosystems, right? How can we build and do market shaping for a whole R&D ecosystem that's always on, for a manufacturing network that's always on, for digital infrastructure that's always on? And the second question that ties into that is, we're really thinking about, as the name of the panel suggests, access to essential pandemic tools, but an always-on system will be most viable and will be most effective and have the greatest public health impact if it's also used for routine health purposes. And one of the things we want to think about is how do we conduct market shaping and how do we steer the private sector in such a way that these systems have dual functionality, right, for routine public health and medicine, as well as pandemic response and outbreak response. So with that, I'm going to turn it over to our panelists. We'll start with just a sort of opening question. If we could each go spend maybe 5 minutes, just start by sharing with us, how your organization is currently involved in achieving more equitable access to essential pandemic tools, and from your perspective, what is really going to be essential for making these market shaping efforts succeed? So we can start with you, Sergio.
Great. Can you hear me? Oops. Sorry about that. So I'm Sergio Carmona, the Chief Medical Officer at FIND. FIND is the Foundation for Innovation in Innovative New Diagnostics. We are based in Geneva, but have offices in India, South Africa, Kenya, Vietnam, and work in many other regions, LATAM, Sub-Saharan Africa, and Asia. We focus primarily on diagnostics. Initially, historically, was very much around TB, but we've expanded to malaria, AMR in the 20 years of trajectory. We started as a PDP, so the model of product development that you may all be familiar with, very laser focused on testing and diagnostics. With COVID, and we are a WHO collaborating center for diagnostics, and we were part of, together with the Global Fund, as the ACT pillar, addressing the acceleration of tools for COVID. So we work along the life cycle of IVDs, from R&D to clinical trials and effectiveness studies or operational research, all the way to access, and more recently also establishing a unit to assess the impact of some of our priority programs internally, and also with the partners we work with, to ensure that, a bit like Tony Blair mentioned it this morning, that we have a well-crafted value proposition that is not only singing to the choir here, but those other players within the ecosystem where testing is critical. So,
great.
Is that a brief enough introduction?
Fantastic, thank you. Richard?
Sure. Just brief introduction. Richard Hatchett. I'm the Chief Executive Officer at the Coalition for Epidemic Preparedness Innovations. We're an organization that supports research and development of vaccines, and we also will be moving into monoclonal antibodies to support the development of monoclonal antibodies. But where access is concerned, I would say maybe just a couple of framing comments. First, we think that you have to begin with access, even in thinking about upstage R&D or upstream R&D programs. And we also think that access is a systems problem. It is not something that is solved by intellectual property provisions operating in isolation. Those are very important, and how intellectual property is managed is important. But access is a systems problem, and I think we saw that during the pandemic. One of the things that we did during the pandemic that was, our organization's commitment to access was helping conceptualize and set up COVAX as an effort to offset the kinds of inequitable access that we knew were going to take place. The inequitable access during the pandemic was driven initially by scarcity. When resources, life-saving resources are scarce, those with the means will use those means to acquire those resources, and we saw that happen. And we saw countries that had manufacturing capacity impose export restrictions and other restrictions to secure vaccine for their own population. But even after we eliminated scarcity, other problems like financing problems, delivery problems, cold chain challenges still prevented access from becoming equitable. And so CEPI, in terms of how we think about access and beginning with equitable access in thinking about our programmatic decision-making, everything that we do and everything that we advocate has an access goal in mind. And so one of the things that we're known for now is we're advocating for accelerating vaccine development, and we've laid out the 100-day mission as should be a global goal. Speed is actually about access because it's about eliminating scarcity and delivering products more rapidly. You will move asymptotically towards equitable access, which is probably at some level an unachievable goal in its platonic state, but you'll move towards it if you can reduce the time it takes to deliver products, the time it takes to scale products. If you promote geo-diversified manufacturing that allows products to be tech transferred and scaled up more globally than was the case at the beginning of the pandemic. And so we bring that mindset, and we are advocating that the world embrace this concept of we have to engineer a system that produces equitable access as a natural output of the system's functioning, rather than addressing access through legal provisions or contract provisions after the innovation and development and manufacturing are addressed separately. So let me pause there because that's probably more than
Great, no, that's fantastic. I just want to check, did we lose Dr. Yang? Okay. Hala?
Thank you, Gabriel. So I'm Hala Audi. I'm the CEO of Unizima, which is part of a group of companies. The group level company is called Universals, and I'll use this to tell you a bit more about what we do. So we are very mission driven, and our focus is on access to biologics for all. And we think we can answer Gabriel's question on equitable access to pandemic tools through two goals that we pursue. One is to democratize and strengthen the research and development base. So this is really about upstream product development. And secondly, through more decentralized manufacturing. So not manufacturing everything everywhere, but we think there's certainly scope for decentralizing the current level of very concentrated manufacturing in a few places geographically and in a few companies. We do this as a for-profit company. We have very patient investors and support from a very broad range of impact-driven investors, but it's a commercial entity in the end that needs to make this innovation work. And so we innovate in two ways, I would say, and I think that joins the system approach that Richard mentioned. So we innovate on the hardware, and then we really focus innovation on the services and the soft skills. So on the hardware side, we are known for having achieved step change in viral vector manufacturing for vaccines and gene therapy. through innovative bioreactors that are more intensified method of production. So the bioreactor itself is yields more product, but it's also smaller, and so you get a cost benefit from the manufacturing process and the fact that your factory in total is on a smaller footprint and easier to build, easier to run. We then applied this innovation on manufacturing to mRNA during the pandemic, and that's another breakthrough that we're really proud of in the group and is being showcased next week in South Africa through the WHO mRNA program. So that's really about the hardware, but we know that having great equipment and manufacturing isn't going to be enough to crack the issue of access of biologics to all, and so there's a real focus in the group on partnering for process development and product development. So we have a CDMO in Belgium that really does that with a partnership approach, really focused on, well, they will take any contracts that they get, including for very precise and niche gene therapies in Europe, US, Japan. But there's also a huge focus on partnering with global health research institutes and global health partners who want to optimize the manufacturing process for new vaccines or biosimilar or new biotherapeutics or biosimilars of existing ones. So that's really service and product development, and then we focus on soft skill and human capital in that we created Unizima, so that's the company I run in the group, and we're dedicated to sending and embedding people in our partners in emerging markets to really help them build these new manufacturing facilities. So that's people to help actually design and build the thing, commissioning, start the process of manufacturing, doing tech transfer, but we also invested in a range of training tools to really train people who are there, because we think that for equitable access, we need people in those countries to be running those factories, not sending people from the West or the North or however you want to call it.
Great, thank you. And over to G.
Hello, everyone. I'm Dr. Yang from Shanghai. I probably is a minority in this conference because my background is I'm running a VC forum in Shanghai. So I'm a chairman of BVCF. It's a healthcare VC fund. So during the pandemic, before pandemic, we invested in BioNTech. Everybody knows that BioNTech is partnered with Pfizer to generate a vaccine for most people to use. We also have invested in a company called Diacata. They're in the US and making all the diagnostic kit for many countries, and for especially they've been used in US for many people to test COVID. We have a company in China. It's called BioStrategy. They are actually the listed company. They're making monoclonal antibody, neutralizing COVID-19 for the therapeutic use. So that's pretty much what we do. We're actually investing all spectrum of healthcare, pharmaceuticals, medical device, and also healthcare service. In terms of healthcare service, during the pandemic, we have a company using AI and also internet technology to tracing the infected people, and basically has a quarantine scheme, help the local government to really preventing the disease. And as an investor, I think everybody probably know we have all the LPs who on our back to asking us to making money for them. So healthcare investment is different from other investment. I would say if in the healthcare investment, most important things you have to remember is to healthcare first, making money second. If you're making this order different, you're never making money. So we always believe this, making money by doing good. So not only just doing a little bit good, we want to do a lot of good. So that's why, as a healthcare investor, it's not easy because these two things are contradictory. Because the LP is always thinking you're not making enough. But then, if you do a lot of good things, you have to be, have a good heart, and then really really helping people. So the healthcare itself basically is starting from goodwill. Because we have to have a good heart, we can really participate in healthcare. But the healthcare, from its beginning to now, is changed quite a bit because we have many people thinking this is a good opportunity to make big money, rather than to helping people elevating the disease, fighting disease, and save people's life. Those original sort of thinking in healthcare has changed quite a bit. Today's market really making the healthcare industry is a very business-like business. So that's where, you're thinking, one thing for all our investors, right? One important thing is to think about how to save people.
Great.
The investors probably have usually has a different thinking. They're thinking how to make money, maximize the return for our investors.
So since we have some investors and some private companies in the room, I think you're bringing us, Dr. Yang, straight to one of the core issues here, and I'd love to hear, Hala, from your perspective, you have investors that you have to, report to and deal with, and I think you also want to do the most good for the world. How is a company like Unizima addressing some of the challenges that Dr. Yang is raising?
So I think you have to embrace the complexity that you decided to tackle, and that's very much the DNA of the group, which is to be very clear about what we want to do and then find ways that are going to be commercially sustainable to do it. And I can use a personal example.
Yeah, I would love to hear a specific example.
Yeah. So my background is in government. I spent the past 12 years in the UK government, actually, as a civil service, working partly on life sciences policy. And when I met the leadership at Unizima and the two co-founders, I really got the potential of what they were doing from a policy and an impact perspective. Because of the breakthrough in the technology that they're bringing, if you can manage to actually scale that up and scale that out in a meaningful way, you can have, I felt I could have way more impact than working in government. So how does it work? I think it takes the ability to partner with public actors, public funders, philanthropic funders, and this is why this community is so important, and find ways that are going to create sufficient margins for groups like ours to survive and thrive and grow. I don't think we expect to make huge profits or huge margins, because this is not the pitch that we make to our investors. Okay. We make a pitch that's more, it's a low risk, medium reward space for your portfolio. As someone from the Middle East, from to play, and all these economies, whatever difficulties there are, have a role to play, and they've shown it many, many times. So that's what we're putting in practice in the room.
Hopefully I'm not putting you on the spot too much, Hala, but Dr. Yang, I'd love to hear how you respond to Hala's pitch that she just made, right? Do you think, would that resonate with you as an investor?
Thank you.
Goodbye. Sorry, you froze for a minute, Dr. Yang.
I think you break up a little bit because it's not very good. I didn't get it.
So Hala was sort of explaining her pitch on why invest in Unizima sort of as a safe and predictable investment, maybe not a game changer financially, but a solid innovation with predictable revenue that would also benefit the world. And I was asking Dr. Yang if that pitch would resonate with you as an investor.
Yeah, I think in certain ways, I would like to say this. I come to China when China is still a developing country. So my initial is IFC. So in that time, they took China as a developing country. That's a 2.5. Okay, after 20 years, so we are not a developing country anymore. So if you believe this is true, then I've been through the transition from the developing country to the developed country. In this case, so you experience all the healthcare in China, how the healthcare starting in this 20 years. So I witnessed the changes. So I think it's important to think for low and middle income country, they actually representing the most unmet need. So as an investor, you invest unmet medical need. Because you invest unmet medical need, you will make money, no matter what. But that's because people are talking about, but really, how many investors really want to do this? And that's a question mark. Because as the investor myself, I look around, we don't see many people agree with me because they probably like to invest in developed country because that would be easier for them making money. So then that's what I said. The order is wrong, then you will never get what we call the market shaping in the way helping all the low and middle income country.
Can I add maybe?
Yeah, of course.
And I'm not into the investment or development, but earlier today we saw from the data presented by Rasmus that key determinants against health deaths, related death to COVID, was against it. If a country or population is against vaccines, more deaths will happen. But testing, was a key determinant in the opposite direction. So for an investor to see that testing capacity actually is a really good ROI because you will reduce deaths in a country or population, I think it's a very compelling argument. Two is that the systems, talking to your point around access, Richard, is that testing, vaccination, or treatment in isolation do not happen, right? So to his point, the other area of investment is in health systems. Primary healthcare providers are now in high-income countries, middle-income countries, and in some low-income countries becoming another opportunity for investors. We see the private sector actually through pharmacies or other channels, including e-health, are providing tests and hopefully other medical measures, countermeasures, right? So it's a little bit related to, is not only traditionally a service provided only by the public sector. I think some innovative investors are seeing that as also an opportunity that provides a broader avenue of where testing and some of these commodities could become available, right? So I know it's not the chief medical officer of funds to push for better investment, but innovation in a broader space of provision of healthcare is becoming attractive and results in good returns of investment. So.
And you did push for better investment, including in diagnostics. So that is the Chief Medical Officer of Fine's job, right?
Not the marketing guy. Right?
Richard Guy.
Yeah, I mean, if I could kind of pull back a little bit, I would just make an observation that we as a society have not figured out how to organize capital flows to address this security problem. We have a variety of security problems, and we have organized in different ways to address those security problems. Cybersecurity has mostly been monetized and mostly privatized, and bringing concepts around, is it profitable and how do you create profitable enterprises to address cybersecurity problems kind of works because of the way that security problem is configured. National security is almost fully financed by public money, working with private companies, but fully financed by public money because that's how the problem is organized. And biosecurity is a problem that we need to figure out how to organize our capital flows. But I would submit that treating the production of countermeasures to address our biosecurity problems as just the same way that we treat the production of drugs and diagnostics and vaccines for routine healthcare problems is to make a category mistake. And it is not to understand that this is a fundamentally different problem. It's not just a version of medical product production. And we shouldn't bring the same concepts of profitability and I would say market fundamentalism to the problem. How we deal with fires actually is an interesting example, and it's kind of a mixed example, which is that fire is a problem that happens because stuff is inflammable, and we don't know what's going to catch on fire or where it's going to catch on fire. And so over a century, we have created a very complex system, including building codes, including insurance incentives, including public funding of fire departments, and allowing private sector, individuals to secure, fire extinguishers for home use or whatever. And so we have this mixed system that collectively has massively reduced our exposure and vulnerability to fire because it's a security problem that we all face. We haven't conceptualized biosecurity correctly yet. And until we correctly conceptualize it, we're going to keep having these debates about how do you make it profitable to address threats like Lassa fever or Ebola or some indefinable future disease X. And we need to engage in the hard work of figuring that out, not just embracing market fundamentalism as the solution.
And I think what you're saying is that it doesn't matter that the profits aren't market-based. Mm-hmm. And for public health and especially for pandemic preparedness, which is like a fire, the profits cannot be market-based. But that doesn't exclude actors from a mixed economy to be engaging in this. We just need to engage with the problem head-on and be really clear and not make a category mistake and be clear how we fund things.
So we heard a challenge from Tony Blair earlier today to think about how do we convince political leaders to care about biosecurity, global health security, to move away from the market fundamentalism approach, as you're suggesting, Richard. What is the alternative framing? This is a question to all four people on the panel that you would bring to a head of state, a minister of finance, a large-scale private capital investor or a multilateral development bank to make that argument when there is not this burning platform of an outbreak spreading all around the world?
Well, I'll start since I framed the problem. The fire example in the history of how we have created these interlocking systems across the public and private sector and through private insurance, that didn't just happen one day because people thought, oh my God, we have a fire problem. Let's design this very complex system that will address it and distribute the cost across society. It evolved over a long period of time. And so actually looking at the structure of how other security problems are addressed is something that I would turn over to our academic colleagues. But look at cyber. look at fire suppression, look at national security, look at AI, and think about how the public and private sectors have figured out, AI probably not yet, obviously, but have figured out how to distribute the costs that are required. Because the payoffs, if you can figure out how to distribute the costs, the payoffs are enormous. I mean, you don't have to prevent a pandemic very often for it to pay off for a century, right? And so any conceivable level of investment that would have prevented COVID-19 would have been worth it. And yet we suffered through COVID-19 and took a $12 trillion hit or whatever it is. I mean, one thing that I would say, and this goes back to the systems approach, and I think the always on is a critical part of embracing a systems approach. We need a biosecurity infrastructure for the 21st century because these are not black swan events. These are a predictable outcome of how modern society is organized. And they're never going to go away. And they're only going to get worse for all the reasons that Rasmus in his heat chart showed you. All the trend lines are in the wrong direction. So this is a problem that we must figure out. I don't have a solution, and there's not a light switch solution. It's an evolutionary process that will probably take decades to implement, but we ought to be able to figure out how to categorize the problem correctly.
Can I go next?
Yeah.
He made some clear points. One, and Tony Blair, right? I mean, first of all, we're singing here to the choir. This is not the group that we need to convince, right? But for politicians to address that, it needs to be within a time frame, right? And we know that you and I, some prime ministers and presidents say, well, you've only got 3 years left. Your solution is not going to re-elect me, right? I mean, let's be honest. You and I heard that a few times. And the World Bank and other large institutions makes 10 or 20-year investments. So that's also a bit of out of frame for someone like that is going to have to be re-elected in the next 3 or 5 years. But there also needs to be some relatable and geographically context where they can actually convince the voters to support him in whether investments are going to be of national importance and good, right? But I think your examples of AI, we all know that electronic banking, we run at risk of those kind of threats. I think COVID showed us that it affected our daily living, our ability to travel, to meet our family and friends. So I think there's something there that whether you are in a low-income country or in Europe, you were somehow affected, and not to forget that. So it's relatable. I think where we're struggling is to see within the time frame, is this a real threat or not? And I think today's data from Erasmus say, well, if 27.5% is the chance in the next 10 years of something happening, maybe that's, I don't know if it's alarmist, if within a range that is acceptable, right? But maybe being eloquent and articulating that this is possible and being prepared is a worthwhile investment is probably where the messaging should be going in a constructive way, right? I mean, we don't want to go and make people panic about fires, as you said, but here are possible technologies accessible, because that's key, to prevent them. Because I think we all know what a fire can do, whether you are in a fancy hotel in London or in a rural area in sub-Saharan Africa.
I think it's really important to put ourselves in the shoes of those politicians, but beyond the politics, also just really listen to the needs and what the country that you're thinking about is saying to you and is thinking. And there is no lack of interest for access to biologics. Maybe not everybody's focused on pandemic preparedness and the next outbreak, but wherever you go, it's very high on people's agenda, including heads of states and Ministry of Finance. For instance, access to monoclonal antibodies for oncology, or good access to insulin, and the inequitable access to vaccines has come to the fore with COVID. So we really have a moment and a momentum to use now. I think what's important for our community focused on global health and pandemic preparedness is not to over-focus on that aspect and really look at universal healthcare and not build a white elephant or whatever they call it. And that's why diagnostics and testing is so important. That's why epidemiology and understanding the burden of disease is important. And I say this as someone who's actually in the business of building vaccine factories, but I want them to be useful. And if we start with multi-product factories that start with fill and finish and actually do insulin, some unpatented mAbs, and move on to vaccines, I'll see that as a huge success. That's what we want to achieve in some of these countries, and these can be. It's not us doing them, it's businessmen and businesswomen in those countries investing their money and really using that untapped growth reservoir of need for access to some of these biologics. And I think this is where we need to go in, support them, and then build the fire extinguisher infrastructure next to it.
Dr. Yang, how would you think about convincing a head of state or a political decision maker to invest more in biosecurity?
Well, I think about security, I don't really know too much because there's a really political issue. So when I do, I'm training, my training is a biologist. So I do a lot of biological work, including molecular biology, all this stuff. So when we do this, when we remember, when I was 82, I was in Harvard. When I first day attended Harvard, there's a demonstration. There's 1,000 people in Cambridge Square demonstrating, say, you cannot do recombinant DNA because otherwise you create a monster out of the lab. So many years now, I think recombinant technology not only benefited human being and it has developed as a main force for healthcare industry. And so we, a lot of time, like to making the issue political sense. So it is not political, but then you were thinking it's really political. I gave an example, for which I don't believe. So I try to convince our government, because so a lot of countries are doing this, because they said they cannot share genetic information. Because if you share genetic information, you're leaking your national security to other countries. I don't believe this. I think it is a whole bullshit. Politicians. I think it is all politicians made up this. So we really fight this pretty hard. But still, this is a law. And then we're basically preventing two things. One is that you cannot do using other people's cell, other countries' cell. You cannot do gene therapy for other people, other countries' people. So that's a limiting science and the limiting healthcare. I think, I'm not in a position to really comment this, but this is just, I think.
Great. Sergio, you said we're preaching to the choir, but I think the choir is collectively still figuring out the lyrics and the melody to how we speak to political decision makers. So we have about 45 minutes left, and we really want this to be an open conversation, and hopefully in a more intimate setting we can really get into some dialogue. We'll ask that people use the mic to ask questions, just so that Dr. Yang can definitely hear via Zoom, but we'll open the floor to questions. And if you could introduce yourself, that would be great.
Thanks. I'm Paul Pronik from Duquesne, US. I coordinate the Asia Pathogen Genomics Initiative out of Singapore, supporting 13 countries in Asia. And I think, just want to put maybe a little bit of a complicated question, but obviously there's limits in private financing for this, right? And governments aren't going to pour huge amounts into biosecurity soon, unlikely. So is there not kind of opportunities for a blended approach where we have these new mechanisms like the Global Fund's pandemic support as well as the World Bank's pandemic fund, right? We realize that dealing with things at a global level is complicated, and countries do want to have more regional approaches or more national approaches. So why not use these kind of financing mechanisms to support things like pooled procurement agreements and advanced market commitments? Sure. For example, for existing products such as genomics, and FINE's research shows that poor countries pay 20 times more than rich countries for genomics, but also advanced market commitment strategies for potential products, right, that might come out of sharing of genomic data. Because what is the incentive for Cambodia and Laos to share genomic data when Pfizer turns around and turns it, makes a vaccine that sells it to the UK 6 months later, right? We don't yet have the checks and balances in the system. So how do we kind of create reciprocal arrangements where there's these financing mechanisms, there's procurement support, and that we're somehow pre-positioning regional manufacturing capacity, both for endemic pathogens as well as for potential new ones? So does that make any sense at all?
Yeah, I mean, to me, sure. I don't know. Maybe let me reframe for it. You put many issues in one question, right? and so the genomics is complicated, not only from a bioinformatic point of view, but also from development. It's like building an Airbus 380 compared to a rapid diagnostic test. So it's a little bit more complicated than a simple test. And as my colleague here just said, it's charged with politics and misinformation, right? So many countries that generated data didn't want to share them because they felt the government wouldn't, put them at risk. South Africa shared their data on early warnings of Omicron, and then you saw what happened, right? Borders get closed, etc. So it's a fine line to share information, right, that then has political or regional, national consequences that could be negative. However, I blended up going to the Global Fund, the World Bank, and the recent call that I think is closed now, received about 600 applications from many countries to access funds, which include surveillance and genomics there too, right? We have been successful during COVID on market-shaping activities like pool procurement, securing some stockpiling, if you want, of testing for low-income countries or countries that may have not had their financial tools to acquire them against, bigger, the G7 or the G20, right? Now, for genomics, a little bit more complicated, right? It's many parts that need to be procured. We are working with not just the suppliers of the machines, but also the reagents plus bioinformatics to see what would that package look like, and then how would the cost of that land in a country like you mentioned, because a lot of in-country duties and supply chain complexities that can almost double the cost of generating one COVID genome in Atlanta and the CDC versus doing it in Jakarta, South Africa, Nairobi, or Cambodia. So it requires a broader multidisciplinary team to look at decentralization of manufacturing without incentives that allow for those who produce locally to compete fairly with those who are manufacturing at large scale. Never mind the quality assurance, etc., of other issues. But Global Fund and the World Bank are now addressing your point of trying to see how procuring regionally or in a fair way could perhaps reduce the cost of genomics and surveillance. Good point.
Just to add on that, I mean, I think you're the one thing that I would take slight issue with you on is that governments aren't going to put a lot of resources into biosecurity. We're actually seeing around the world governments create institutions modeled on BARDA in the U.S., CEPI HERA has now been created. Japan has created SCARTA. Singapore has PrepVax. South Korea has their set of institutions that they're investing in. India is building pandemic response centers. I mean, there's a tremendous amount of money flowing at the national level into national assets. And what's interesting is that at CEPI, we've gone around and talked to many of these nationally oriented entities that are focused on domestic security to understand what their priorities are. And their priorities are driven by the geography of where they're set. And so there's actually a nice dispersion of diseases and disease types that are being prioritized. One of the things that CEPI has called for is the creation of a global vaccine library where we have, on the rapid response technologies that we have exemplars for different kinds of viruses so that we have a capability to pivot, much as we pivoted from SARS and MERS vaccines to COVID vaccines. So there's a lot of money that will flow globally in aggregate, but through national channels. And that's not money that I think we can depend on international institutions being able to coordinate with a heavy hand. It's going to be a decentralized effort, but light coordination and communication will help that effort add up to quite a bit more than it would if everybody just pursued their activities in silos. There are other efforts, you mentioned regional efforts and pooled procurement, where the shape of the problem sort of aggregates at a certain scale and where it can depend on the kind of mutual affinities that countries that occupy a particular geography share and their willingness and trust that they build up over time working together on a whole variety of issues, where pooled procurement, shared supply chains, indigenization of supply chains to support indigenous manufacturing, for example, might be very possible. And then you're going to have some efforts that have to be addressed at the international level. And so you're going to have problems operating at multiple scales requiring different degrees of coordination and formalization, but which you could imagine adding up to this biosecurity infrastructure that I was postulating.
I just want to check, do we have anyone from Gavi in the room?
It's in the other room. Yeah.
I just want to also respond on that. Gavi is developing their AMC, their advanced market commitment right now. Gavi's bread and butter is not biosecurity. They're developing an AMC for vaccine biologics manufacturing in Africa, and it'll be really interesting to see if there is a use case for biosecurity-related products from a Gavi advanced market commitment. I personally think it would be a missed opportunity if you can't use it that way, but that's not what their core focus is and not what their board-approved mandate is. So, yeah. Go ahead.
Sorry,
A mic?
I was...
Do you have a microphone?
So this is Carmen Pérez Casas from Unitate, also a Geneva-based organization working on introduction of innovation and access to innovation, and having led the work, for example, on COVID therapeutics on ACT8. And I wanted to make 2 points. Only one is in this very good question also. We have reflected and seen, actually, and learned the lesson during the last pandemic that there was no sufficient flexibility on funding to actually do those kind of at-risk investments. So I think for the next, we actually really need to work on another kind of framework in which we can actually, even before the products are approved and recommended for use, start working with manufacturers to seed for enough capacity. This is still true now for a potential surge on COVID, that we still need to think on the stockpiling Sergio was mentioning, or other items, but also for a potential new pandemic. And actually, the metrics then for success will need to be different that funders will, qualify the response with. Because if you only measure on numbers of lives saved, but not on numbers or preparation for life saved that eventually are not needed to be saved because there is no pandemic, then it's great. But, we have to kind of push for different kind of metrics or to measure preparedness. And my other comment is on the synergies. So there has been you had also touched upon that before, Hala, and also this morning with the first speaker, and the need to have synergies across not only the different medical countermeasures. I think we need to look for areas in preparedness that can actually meet different purposes versus competing for funding and versus competing for implementation work. Anyway, also the lines are quite blurring between prevention therapeutics, for example, with the monoclonal antibodies being positioned for both. So that will be very important. And also the dual purpose you mentioned before. So not only dual purpose in terms of prevention and treatment, but also with the current pandemics like HIV or other priorities that are in the countries. And my last comment there is, while yes, we need simplification, and for Tony's Blair's politicians, but sometimes we need to look at detail. And for example, you mentioned before, Hala, the potential synergies between monoclonal antibodies production and vaccines production. That's fantastic. But there is not such a synergy, so for example, in long-acting antiretrovirals or long-acting contraception that was mentioned this morning, which are small molecules and are not going to be manufactured with the same technologies, etc. So we need to look a little bit on fine-tune what are the investment needed to accomplish all of those objectives together with the particularities of each of them, but looking at rather than fragmentation synergies when possible. Thank you.
Thanks, Carmen.
There was someone.
Yeah, I think you had your. Yeah. Sorry, that's probably not the most efficient next person to go to.
Many thanks. My name is Nameen Varawala, and I serve as Chief Medical Officer at Relief Therapeutics, a Swiss biopharmaceutical company. That's quite a mouthful. So I loved and was intrigued by, Richard, your analogy with respect to firefighting or being prepared for fire as a source of threat. But can't help pointing out that if there was a difference, it's the fact that some of the tools that we're looking for pandemic preparedness, such as microbiology, genomic testing, bedside testing, biological manufacturing for a number of products, digital solutions, are required here and now for a lot of other indications. And indeed, there are a number of actors in the private sector who are busy working on these and indeed running very profitable businesses providing these tools. So my question is, how might they be used? And maybe Dr. Yang too would like to comment. How might they be used to use these capabilities so that they can continue adding to their profits, return value to their investors, as well as help with the pandemic preparedness initiatives?
Plenty.
Dr. Yang, do you want to take that?
I give it a try.
Okay.
Well, I guess this is always the situation we struggle with, because we know there is unmet medical need. The unmet medical need always has a, I don't want to exaggerate it, it always has a two kinds of unmet medical need. One is for rich people. The other one is for poor people. So where you want to bet your money? So and then I think lately the biopharmaceutical and biotech industry like to serve for rich people, rich unmet medical need. Because you can see we developed a lot of very high price therapeutics. But you see those kind of therapeutics can, how many people can be benefited.
Yeah,
but if we don't develop those, our healthcare industry never make a progress. We will stuck in certain level, never going to move. So when we have a new disease, we don't know how to deal with. But then the issue is that how we invest this area for really need the unmet medical need. That means middle and low income people need those healthcare, but still make a profit. So that's things we struggle with. So a lot of time you have to sacrifice certain ways to make this investment decision. As you said, those new technology will driving basically the next wave people, defense on the uncertain disease. So we need to do it. We need to really invest into those technologies. For example, RNA technology really blossomed in the COVID-19 case, because everybody knows vaccine business in the pharmaceutical industry has always been regarded as the lowest industry because they're low tech. Many vaccine was actually made with a very old technology. Give you an example. Flu vaccine was made still with a chicken egg. As how many years we developed this technology? We don't have a new technology. In pharmaceutical industry, if you're not doing well, they will send you into vaccine business. That's how bad that is. So, but then things change in COVID-19 because we have a new technology, DNA vaccine, RNA vaccine, and all other subunit vaccine was actually emerging as a lot of innovations come out. I hope these things continue because vaccine business usually doesn't mean you will, in this industry you can make a lot of money. Profit is not very good usually, but until this COVID-19, I think some company really made a lot of money. But then I guess, if you look into China, right? The vaccine business, government regulated, they never want those company making enough money. So because it's being used for many, many people, it's not like this is only given people who can afford this. They need everyone to use it.
Okay, so hopefully, hopefully we're not offending too many people who work in the vaccine industry in this room today. I think Sergio and Hala want to respond.
I think there are, to your point, I think there are, what do you call them, rich people or poor people, but there are some low and middle income countries, for example, to your point, where investments, let's say in HPV vaccine or HPV testing, actually solves for both women in high income countries and those that are affected by other co-infections like in sub-Saharan Africa. So I think it's not always a one or the other. There are certainly opportunities in digital health in Asia where investments are being made that are profitable. HPV is one case, and there are others where both can be of interest, both commercially for the high-income countries as low and low. And even in vaccines like measles and rubella, where there has been hesitancy in the US and the UK, these are not only only intended for low-income countries, but they're becoming valuable now, even more so in high-income countries. So I think it's not one or the other.
However, I must say that the pandemic has broken through the income barrier. We're all in this.
Yeah.
Rich or poor.
If we remember that lesson, though, right?
Yeah.
Hala, do you want to jump in as well?
I'll differ. I'll pick up on the economics, but let's hear the question first. You've been waiting.
No. My name is Sean Claydon. I'm here as part of the IFPMA delegation. I'm actually the chair of their vaccines committee. I just happened to have the microphone before, but I think, just to your point, I would agree that in many cases, vaccines that are used in high-income countries are delivered through Gavi COVAX in the pediatric setting. You've mentioned some of them. But actually, my question was something else. There are mechanisms. I've been really excited to hear some of the ideas about how to use manufacturing to really create a sustainable demand. And I think that's going to be incredibly important for the future, because developing manufacturing facilities that cannot be used will mean that they're not sustainable in the long term, and equally won't be able to be upscaled quickly. You need all of the things that we mentioned: trained, expert staff on the ground, regulatory procedures in country, in region to do this. But the question I was going to pose to you very much was, I was very excited this morning to hear about a common thread through a number of the from the speakers, the panels, as to one way of bringing forward sustainability is to really look at adult vaccination or life course immunization. And so when we look at, even in high-income countries, that flu vaccine, the uptake is extremely low. And in those middle-income or lower-income countries, it's even greater issue. We've seen great progress during the COVID-19 pandemic at accessing some of those at risk, even in low-income countries. So how would what do the panel think is the way forward now to really capitalise on some of those things that have either worked well or started to be built to really get to not only the volume of products you need, whether they be vaccines, diagnostics, therapeutics, but actually looking at how to actually then get them to those people who need them most, and perhaps creating that life course immunisation in all countries of the world, actually, especially those that were underserved in the first number of months of this pandemic. So,
yeah, no. If I could jump in on that, I mean, I think if there were one single thing that we could see be sustained out of the pandemic response, one single thing, seriously, it would be life course vaccination. The benefits of building on the delivery mechanisms that we put in place to deliver COVID vaccine to vulnerable populations, which are going to be the same groups of people that are going to be the most vulnerable populations for any conceivable future pandemic disease. It's always the same people. It's always the impoverished. It's always the elderly. It's always the immunocompromised. Occasionally it'll be infants. But the benefits of creating a system that would deliver benefits in the here and now in terms of delivering vaccines that improve quality of life, probably save lives, the same systems that could deliver these long-acting products in terms of increasing demand, which would support an enhanced manufacturing infrastructure. It would provide a capability of resilience to respond, greater capability already embedded in the country with channels to get to the populations that are at greatest risk. There is a brilliant opportunity that we have, which if we neglect it, it will go away in a few short years, and we will have missed the opportunity to turn the tragedy of the pandemic into a victory for the delivery and democratization of healthcare products more generally. So I couldn't agree more that life course vaccination ought to be everybody's priority because of the cascading benefits that would come from it.
And if I pick up on the economics of that, which is more my background, and I think it comes back to the first question that we had, and how governments and ministries of finance see this. I think there's a real opportunity to be quite optimistic and capitalize on what happened during the pandemic. And I think governments are not going to want to pay through the roof for some of this, but that's why it's so important to broaden the research base and the product development base. And that's what gives me a lot of optimism and hope, is the work that CEPI, and I don't say this because Richard's next to me, but also others, are doing with partners like Institut Pasteur de Dakar, with who we work, the rest of the Institut Pasteur network, CAMRI, amazing research that goes on in Malaysia, in Indonesia, in many, many countries. And I think broadening that research base is incredibly important to just get more chance of having more products that are meeting the needs of poorer people and middle class people in in developing countries and sometimes rich people in developed countries. But then once you have that, and we've built that, and I think that's hard work, but that's what's needed to be done, and that's what gets me excited about this. I think there's a political and economics conversation that becomes much more easy, and that we have to have. And it's not like the model of development aid, that's based on bilateral aid or multilateral institutions has worked so well. Nobody and I said I worked in the Treasury for 12 years. Nobody's going to defend that, for very long. Everybody's looking for better solutions. They don't want another expose of the problem. They want some of the solution. And I think in global health, some of the products we're working on are global public good by definition. It's like they were made for the textbook Economics 101 to be explained about externalities. So I think there is a push, and I think Michael's here from MedAccess and many others who, Gavi was mentioned earlier, they are working on this African vaccine. We really need to push that conversation and push for a different way to buying these global public goods. And it's important for antibiotics and AMR, it's important for pandemic preparedness, it's relevant in so many ways. So I just want to finish to say, let's allow ourselves to dream about a different way of buying some of this stuff, because I think serious people in ministries of finance actually are listening.
I just want to add one thing on your point about sustainability. If there is no market or demand, you won't have it, right? Even if they are funded and supported. So one thing that we've learned from vaccines and testing is that it's, again, we're not competing with vaccines or testing. There are hepatitis B vaccines that we missed 3 years of vaccination because of COVID, right? So we're going to need testing because we missed a cohort. Many girls in many countries, now it's the third year going, that have not received HPV vaccines. So they're going to now miss the opportunity, and they're going to require continuous testing for life, or at least twice in a lifetime, right, to avert cervical cancer. But we can, without involving countries and communities, demand is not going to be generated, whether it's for flu vaccine in high-income countries or HPV vaccines in sub-Saharan Africa. Demand is generated by knowledge, by being able to communicate at a language that is appropriate within those different levels of the health system, so that women and mothers and daughters come to the healthcare facility and demand the vaccine for HPV or testing if it's age appropriate. There are many opportunities where local manufacturing, either for tests or vaccines, can the repertoire be, as I think you're alluding to, be more appropriate for the region. We had last year 29 cholera outbreaks, and still a vaccine that has been around, I don't know, you help me, decades, and yet we still run out of cholera vaccines in 29 outbreaks last year, while COVID and everything is we're distracted by climate change, right? So I think there are clear opportunities that are regional of importance that need to be used to generate demand from not only the top, but also from communities upwards.
I want to make one shameless plug, and thanks Richard and the group for highlighting the importance of the life course vaccination point. One action item for our group really coming out of this event is to scope a series of real-world evidence and implementation pilots around the world, not just in low and middle income countries, but including low and middle income countries, specifically on adult vaccinations and life course vaccinations. And so folks who are interested in the real-world evidence implementation side of that agenda would love to follow up afterwards. I think we've got time for maybe 2 or so more questions. So Dr. Agus, who's scowling at us right now.
Well, I'm frustrated, right? We keep saying the same thing. Let's educate people more, and they're going to get more vaccines. If we make the vaccines locally, people are going to take them up more. We've been saying the same thing for a long time, pre, during, and post-COVID, and it's not working. So the real question is, why can't we mandate some of these things? If we want aid for a particular region, you need to do something for the health of the region, the economy of the region, which are these vaccines. We mandate them in children. When we talk about adult life course vaccination, some of these vaccines, but I'm trying to be controversial here, obviously,
Sure.
but some of them should be mandated. It's not an optional thing. Because the education part, no matter how well we talk about it, to get normative behavior change, you need leadership in healthcare. And right now, globally, there is no leadership in healthcare.
Okay, since we're talking about, but I like to differ. I was in Nairobi about 3 weeks ago, and talking about local leadership, there are women that are survivors of cervical cancer that have taken this on their own, right? With poor material, with very little support, right? Maybe politicians left them behind, maybe the healthcare system left them behind, but they realized that the little dosages that they had, right, needed to go to the mothers, but to the daughters, but the mothers also, of these eligible girls should also be screened, right? So if they're coming to a health facility, why can't the opportunity be taken for both? So that after, I think the cervical cancer elimination strategy was launched in the middle of the pandemic, so no one paid attention. A year later, we get invited to WHO to celebrate a year of this, and everyone was caught slightly unaware that this had even happened, right? But when we went to countries, it was quite different. That suddenly, if we were providing very basic support, that it was done in consultation, and I'm talking basic material written in their own language, with graphics that represent their own community, that suddenly politicians came running, because if demand is generated and there is no budget or a strategy, suddenly they became a lot more involved in a maybe positive way, right? Because there was demand generated by local leadership, local communities, right? Often, as you pointed out, this comes from the top, right?
I got that, but organic demand is going to get you so far, and I'm all for it.
Yeah.
Why not do both? Grameen Bank did it, right? They required certain requirements in order for you to get a loan, and all of a sudden, the health quality of the individuals went up dramatically.
Yeah.
There's no reason we can't do both.
The issue there, when that happened, is that the power of procurement of high-income countries for specific vaccines like HPV is so much greater that then you get left with the leftovers or nothing, right? And interrupting a cohort year and year of girls that do not get vaccinated is really hard to, at that age, to restart a program. So I agree, why do not do both? But that's where inequality comes into play.
No, but if we know demand, we can forecast demand accurately because we've mandated, we're going to be able to do much better do the supply and the manufacturing. That's a different story. So I do think requiring will help a lot on the manufacturing side. We can't predict demand most of the time.
True.
I think, David, the experience with the revolving fund in Tahoe is illuminating and encouraging, frankly. When the revolving fund started in the 1960s, maybe, there were 3 countries in the Western Hemisphere that had adult influenza vaccination programs, and now they're 40 or 45. I don't know what the exact number is. But it was because of the pooled procurement, and it was because countries that previously had small volume demands could suddenly get the benefit of bulk purchasing through the revolving fund, that they were able to begin to offer influenza vaccine, which generated demand. It is a decadal process. It's not overnight. Mandates are easy because they're overnight, and they elicit massive resistance and civil unrest and polarization. And I'm sort of parts to them also. Yeah, they are, but you're trying to generate long-term demand, and having access to a product, if it provides demonstrable health benefits, will begin to generate demand, and over time will begin to generate societal demand for the product. So I agree, there are obviously benefits to doing it, and it's one thing to have a mandate that's delivered through the World Bank through a funding program that creates that's a mandate to a government versus an individual mandate. But it seems like there are mechanisms that we are not exploiting that could serve the needs of developing life course vaccination and improve healthcare outcomes and provide all the benefits that you know very well, that we're not exploiting. And we're missing an opportunity. Mandates could come into that, but it's not the only thing.
We're never going to do a mandate. But if Michael Bloomberg proposed a mandate for large sodas in New York City, and there was crazy pushback and debate. With that discourse, shopping changed in New York City and behavior changed. And so the argument is we have to shake things up and create a discourse among the population. And doing small experiments here and there, pilots are all fine and good, but this needs to scale to 1 billion plus.
Yep. I think we have time for one more, hopefully less controversial question to wrap us up, or maybe more controversial. Two more.
Hi, I'm Michael Anderson, CEO of MedAccess. We're a finance company that de-risks demand for medical products, including vaccines. And I think it turns out, actually, it is reasonably straightforward to predict demand if you do the granular research. It is possible. And we use financial tools to help smooth out that demand so companies can manufacture more at lower prices. So on. My question was about, I wanted to pick up on Richard's point about financing and how we allocate capital to biosecurity. As we saw with the pandemic, there is an enormous willingness to pay once the pandemic's in place. Everyone, the governments and individuals are just cranking open their bank accounts to pay once the pandemic's in place. But a really low willingness to invest and pay in advance. Now, it's true, Richard's pointed out, the various BARDA-type entities are being set up, and that's a really good thing on the public side. But I don't think we've seen an equivalent investment quite so much on the private side. As Dr. Yang will explain, I'm sure, in depth, that LPs are very impatient about returns, and they're not willing to wait a very long time for returns. There has to be a constant story about how are those returns going to materialize. But I'd like to propose there is real room for a private sector approach to preparing for that enormous willingness to pay. And the way to do it really is to think about getting small payments up front, not relying purely upon governments to do it. But if you think about AMR, we've known for 2 decades that there's an AMR crisis coming. It hasn't yet hit, despite Hala's fantastic efforts in a previous life. We still don't have a solution for the AMR. They're getting the upfront investment and the antimicrobials we need. But it seems to me that the fire example and the cybersecurity is a good one. That if we could find a way to get private contributions. And there are ways of doing that. I'm not going to take up more time, but you can create pandemic bonds. There are, admittedly, the World Bank ones didn't work very well. We do things where we can create parametric contracts with companies that if they meet certain conditions, then we can release the funding. I think there's some big private sector solutions here that we have not tapped into on the private finance side. And I would just like to add that to the mix because it can't be just public sector response. Thank you.
We'd love to mobilize some of those new solutions with you coming out of this the event. So thank you. Last question.
Thank you. Thank you so much for the panel. My name is Serena Martinez, and I'm a DPhil candidate in American History at Oxford. I am curious, so I wanted to pull on a thread that I think, Richard, you mentioned, on sort of combating this fundamental idea of market fundamentalism. And I think, even just reflecting on some of the comments that I heard earlier, it feels like in some ways COVID kind of initiated this crisis of accountability. And so from an institutional level, it was like who's holding the scientific community accountable, who's holding governments accountable. Speaking in the US case specifically, we saw a lot of grassroots activism. And so I guess I'm curious how you all think about mechanisms of accountability and from an institutional perspective, like who holds you accountable? Because it seems like in market fundamentalism, the idea is the market will. But if that's not actually what's working, how are you sort of pushing that? And how do you think about it in relation to your work?
Who's holding you accountable?
So, well, I mean, in some cosmic sense, ultimately, we're holding ourselves accountable. And so the systems equity perspectives that I described, and putting equity first and putting biosecurity first actually in your decision making is sort of an ethical choice, right? It's because like you're trying to achieve goals around equity, goals around advancing biosecurity, and you've been entrusted with resources, in our case by governments and philanthropies, to do the job. And yes, they hold us accountable at some level. I mean, we have an investors council and we have to justify what we're doing, but it's within the actual decision making, we can hold ourselves to a higher or lower standard of, are we actually using these filters, these upfront filters, to make our decisions? And that's not something at the end of the day that sort of remote funders are going to bring the kind of expert knowledge to actually hold you accountable. So I'm not trying to evade your question. And we're an international organization which is decoupled from, the parochial requirements of governments and elected officials. So elected officials during the pandemic behaved in a way that, illustrated their accountability to the publics that elected them. So they implemented, travel bans and export restrictions and the kind of self-interested behavior that produced a very suboptimal global outcome. And international institutions are, depending on how they're configured, I mean, WHO has a different challenge than we have, but we also have an opportunity to take a broad systems perspective and think about how the entire system is functioning, and then making the choices of how we allocate our resources to try to promote better system functioning or better system outputs. And national governments and even regional efforts can only do that within the context of that's, either the national or the regional sphere. And so I feel very privileged to be operating in a nonprofit international organization where I'm not responsible to the UK public or the American public or the Russian public or the Chinese public or any other public. My sphere of responsibility is like, how do we solve the problem of epidemics and pandemics, and what can we, given the constrained resources that we have, what can we do with those resources to promote better system functioning? And as I was saying at the beginning, at the end of the day, we're setting our own standards of accountability and holding ourselves accountable. Yes, ultimately, the funders can hold us accountable if they think that we're being delinquent or irresponsible or doing the wrong thing. But the level of accountability they can hold us to is lower than the level of accountability we can hold ourselves to.
I want to give Dr. Yang a chance to jump in on this one. Dr. Yang, who's holding you accountable to prioritize unmet medical need?
Well, I guess we have to hold ourselves accountable, just like Richard said. I guess that's most important.
We do have an online question through the app.
I think we're at very close to time. Maybe you want to quickly share what it is? And
it's another accountability question on vaccine accountability. So in countries whose vaccine clinical trial data does not look exactly right, and vaccine effectiveness data lacks transparency, resulting in defective vaccines being in circulation among the population, how can international organizations step in and ensure that accountability?
Very specific and technical question. Does anyone want to take a stab at that one?
Let me try and do that one and go back to the previous one, because I think it's really interesting. But counterfeits and poor quality drugs are a huge problem. There's huge efforts into pharmacovigilance and tracing these, and it's an important problem that I think we're all aware of. But what your question made me think about, so I think it's, in terms of accountability, it's our own moral compass as individuals. I don't think I'm important enough to be held accountable by a bigger thing than this, so myself and maybe my boss and my board. But what I don't want to lose here is how much global health has created amazingly valuable instruments of international collaboration. And most people I know who are not into global health that's most of my friends and family, they're very skeptical and cynical. They're like, what are you doing? It never works. It's not. And you have to explain, no, that at some point somebody woke up and created Gavi. Somebody made Unitate. I was at Davos, of all places, at the initial meeting that created CEPI, with the German Minister of Health and some big pharma, amazing people. I'm not going to name names, it doesn't matter, but they made it through their leadership. And these are really collaborative international initiatives that we should really become better at talking about and
not forgetting.
Yeah, and propagate.
Sergio, do you want to wrap us up?
Yeah. Gee, on that issue of accountability, I don't think it's about how important you are or Richard is or I am that holds us accountable, right? I think we are accountable in the case of FIND to those individuals that still today do not have access to testing for not even COVID, for malaria, HIV, and TB, and there are many. So some of them I see or used to see when I worked in South Africa or in Sub-Saharan Africa. That is a huge reminder of why we're here, why we are not, for an egocentric kind of view, your positions, the two of you, are critical to deliver on those individuals that are still being left behind for diseases that have been here for a long, long time before COVID. And sometimes we forget, but it's critical at least to keep my moral compass straight, to remember why I studied medicine and who was I intended to serve. And we forget that. So it's women, in the case, that are exposed to HPV and with a test that could cost less than $10 could avert a disease that it's really horrible to die of many people still in many countries dying of HIV every day when there's access to single-digit dollar tests and treatment that still do not have access to. So I would say not only to the funders, my board, my boss, but also to ultimately the recipient of a vaccine, a test, or a therapeutic. But good question.
Thank you so much, everyone. I do want to emphasize, first I want to thank all of our distinguished panelists. And I do want to emphasize, again, the Global Health Security Consortium, which helped put on this event with, under the leadership of Rhodes, is going to be pursuing a lot of work on life course vaccination, pilots, and market shaping around clinical research, as well as hopefully manufacturing ecosystems. So I'm happy to chat more. Find me or one of my colleagues during the coffee break or later this evening. So thank you so much, everybody.